So look, it's my pleasure to introduce our keynote speaker, Associate Professor Sonia Wutzke from the Australian Prevention Partnership Centre, where she's the Deputy Director. Sonia's research interests are manifold, but include the practical application of systems approaches to improving the design, implementation and evaluation of large-scale public health initiatives, the power of local communities to drive innovation and change, which we've just heard about and which I think is really a focus of the Western Alliance, and approach to operationalising complex research partnerships, again, central to what we're trying to achieve at the Western Alliance. Sonia, I understand, will give us an overview of the structure of the Australian Prevention Partnership Centre and an example of some case studies to try and illustrate that. And we look forward to hearing from Sonia. Thank you very much.
Thank you so much for that kind welcome, and good morning, everybody. Is that wobbling, or is it just me? No. So you look there, though, don't look at me. And I've got a clicker. Okay, so look, thank you so much for the opportunity to present to you today. I will confess at the outset, I've done this thousands of times, but still find it quite daunting to try and think about what messages will connect most with people in the audience. So I've decided not to do that now in my more senior career. I just will give you a broad brush overview of what I know about the work that we do, and I'm hoping that it will connect with most of you, and I'm very happy to follow up further, because there's only so much you can get through in a short period of time. So I'll start by just referring to the iceberg. I put that on a few slides throughout my presentations, one because I just think it's really pretty, but also because I think it really describes the systems approach. The top of the water looks relatively, you can see it, you can touch it, you can feel it, you can understand it, but it's the complexity below the water that we're all trying to deal with in our day-to-day routine. The second thing I wanted to just reflect on, which doesn't really, isn't conveyed when people are their bios are read out, is that I have two passions in life, professional passions I should say, clearly, in case my children hear. My two professional passions are the use of evidence to make sure that our next practice is as good as it can be. And that evidence isn't just from research, it's from policy and practice, people in the field doing the work. And that I personally, and the work that I'll present, equally values and tries to surface the insights from that policy and practice that happens on a day-to-day basis. The other thing I'm really passionate about is partnerships, research partnerships, which I think this forum exemplifies. So I don't think we alone can deal with the complex problems that are facing us. We need partnerships between research, policy and practice, where there's diverse views, multi-sectoral people coming together. So a common theme in the work of the Australian Prevention Partnership Centre, which I'll talk about a bit further, is co-production. So we don't allow any piece of research to get up and funded unless there's voices in that room of people who, not just the academic researchers, but people working in the system who actually have insights that we just can't get from one person. So with those caveats, what I'm planning to do today is to really, as introduced, just give a brief overview just to set the scene about chronic disease, a little bit about the Australian Prevention Partnership Centre, and then just 3 case studies of how we're applying systems thinking. There's many more, but I've just picked 3 that I'm hoping will connect most with the audience. So before I get going, good training, just to acknowledge the people that have worked significantly on the data that I'm presenting, and also to, of course, acknowledge our funding partners, and I'll talk about them a bit further when I describe the centre. So, the problem and potential of systems thinking. So I'm going to go through these slides quite quickly because I'm hoping that you all appreciate the significant impact of chronic disease. So,
could you the microphone's just a bit too far away from you.
I'm not going to touch it, I'll bend down. Is that better?
Oh.
Don't break it.
I try not to, how's that?
Is that better? I'll talk louder anyhow. How's that sound in here? Okay, so these next few slides are really just to set the scene. Chronic disease is our biggest health problem, major problem. it is a complex problem, non-linear, multiple causes, all interacting together. So really, something really tricky for us to try and deal with. And one could go home and drink a bottle of wine and just go, it's all too hard, which it is some days, but prevention is powerful. And there's a lot of data, increasing volumes of data about the effectiveness of preventive interventions and also the cost effectiveness of those interventions. And I should just, pause there and say the prevention that I'm talking about here is prevention of lifestyle-related chronic disease. So our focus throughout is on the key suspects of physical inactivity, poor nutrition, smoking and unsafe use of alcohol. So they're the sort of 4 risk factors that are common amongst all chronic diseases and also among a number of other health conditions like cognitive decline. So they're the sort of focus of our work and where we think as a community we could really focus on. Systems thinking, as a number of us had a great workshop yesterday, it's really just about a different way of thinking so that we can unpack complexity so that we are then better able to intervene and make significant and sustainable change. And I'll talk a little bit more about that, but just to set the scene, big problem, we know prevention can do something. We are investing a fair bit in prevention, so I've done a lot of research looking at what I'm now labelling the roller coaster of investment and disinvestment in structures, in policies, in task force to try and intervene in chronic disease. But we're just not getting there. So I think a new way of thinking is required, and that's where I think systems thinking can add value. So what is a system? As you can see from that slide, it's an interconnected set of elements that connect in a way for a common purpose. And systems thinking, in my view, is 2 things. It's a way of seeing the world, and it's also a set of tools that we can use to help us better understand and unpack that complexity. And it's probably some of those tools that I'll explain more about in the case studies. So I've just put up there, these are the kind of things, systems scientists in my view are very jargony, but the sort of 3 things, it's so many different concepts, so many different tools, so many different theories. But there's sort of really 3 elements that bring people together on the one page, and they're about interrelationships, making sure that you have multiple perspectives, because if you're not all in the room, you don't all own the problem and you can't all see your place in solving the problem. And there's about having boundaries and knowing the scope of the problem you're dealing with. The 4th element I put down there is always the leverage points. So I'm a strong believer that we actually do a lot. We're all busy, we're running around, we're trying to do a really good job. But I think through some of the systems tools that I'll talk about later, if you can unpack that problem, you can look for, if I say tipping points in the system, where actually if you intervene in that, you can have a significant change in the rest of the system. So that connects to this slide, which is around comprehensive approaches versus systems approaches. Now, I'm not going to go through all the detail in this, but just really the key message for me, connected with my previous comment, is we all know we need to do multiple things, layering of interventions and strategies to achieve change. That's fantastic. But what might happen is that if we do too much, we actually end up diluting our effect. So I think through systems approaches, what we're hoping to do is to better identify those key tipping points, those leverage points, where you can perhaps invest more strongly to have a more significant impact. And you possibly might even disinvest or stop doing some things. So who are we? The Australian Prevention Partnership Centre. So I'm the Deputy Director of this centre. We're an NHMRC funded partnership centre. Which means there's a 3rd in the making. There's 2 in existence at the moment, us and another one around cognitive decline. Significant investment, new way of funding research from NHMRC. We are a 5-year initiative. We're now in year 4, which is rather scary, but that's the reality. The funding was provided half through NHMRC and then half through our funding partners who I referred to earlier. So New South Wales Ministry of Health, ACT Health, the Australian Government Department of Health, and HCF, a private health insurer. So right at the outset, we've got people skin in the game committing to this program of research. We're administered by the Sax Institute in Sydney, which is a leading Australian agency in bringing together policy, practice and research. So as I said earlier, our work is co-produced by policy, practice, research, and basically our whole purpose of being is to really see if there's a better way of articulating, making recommendations for an effective, efficient, equitable system for the prevention of lifestyle-related chronic disease. Long thing. I'll pause there and say I loved the analogy with the escalator because I'm all for that. So my view is let's try and keep people off the escalator in the outset. If I'm having a down day, I think we have a sickness system. So we all know, we have a reasonably well understanding if we feel unwell, we go to our doctor, we might see a specialist, we might end up in hospital. But are there similarly tangible structures, evidence, people who are committed to preventing illness in the first place? So we have this concept as a centre that is there such a thing as a prevention system? And that's where all our work really hopefully will be culminating. We don't think there's such a thing as a PBAC for prevention, but maybe there is, not sure. So just a little bit more about us as a centre, because it's a little bit hard to understand because this is my only slide to tell you exactly who we are. So at the moment there's about 150, I call them all investigators, but they're not all academic researchers. They're people working in the health system, across about 28 agencies all across the country. And we have about 35 projects underway at the moment. They're all separate projects, but the theory and my job is to make sure that the whole comes together and is greater than the sum of the parts. In Victoria, I did try to think if there's some names I can drop, just so you have a bit of a connection that this is actually real. We work closely with a number of universities and sites at Deakin University, Rob Carter, who some of you might know, Melbourne Uni, Billy Giles Courteye, Alan Shield, who's now at La Trobe, Penny Hall, who's actually at Sydney Uni but based here in Melbourne. So there's some really clever international experts in public health, chronic disease prevention and systems approaches. And we have a really good website, so I'm happy if you want to have a read through that, and I'm happy to talk more. So that's who we are. But how are we applying systems thinking? And this is where I was just going to give you sort of three tastes of how we're doing that. So the first project, can you hear me all right now? Does it come? Okay. So the first project is a project on concept mapping. So this is a technique, and I'll explain a little bit more about the methods, but it's really a technique for understanding, synthesising and then visualising multiple diverse views around a particular problem so that you can then see what other people are seeing, bring all those ideas together and hopefully together come up with some solutions that are meaningful and feasible to that group. So for us, the project that we undertook was, it's a virtual exercise, so it all happens remotely. We had a relatively small sample size, and I'll get onto that, but in theory, you could do this with thousands and thousands of people. It makes no difference. It's all done virtually. It has 3 stages that you can see there. The first one was around brainstorming. So we literally emailed all our contacts and said, here's your prompt statement. One specific action we can take in Australia that will improve the prevention of chronic disease is ... And people just went for it and they put down whatever they thought made sense to them. We then sorted those statements into sort of meaningful clusters and then asked people to rate those individual statements, which then of course rated the overall cluster on perceived importance and perceived feasibility. So we were very fortunate that we were able to contract with Professor William Trosham from Cornell University, who actually developed the systems concept mapping software, which was the sort of the grunt behind the analysis, which was really involved a number of multi-dimensional scaling and cluster analysis techniques. So this all happened virtually with people around the country. What we ended up with, we had just under 80 people who participated. They brainstormed 131 different statements that we then, as a sort of advisory group, synthesised into 95 statements And then the software then was able to do the cluster analysis that created the 12 cluster solution. Sounds fun, doesn't it? It actually kind of is. Some people hated it. I actually liked it. I think it's different research question is who likes doing it and who doesn't, but that's for another day. This is what you end up with. Looks impressive, doesn't it? But it's actually quite nice if you take the time to look at it. All the little different numbers are the 95 statements, and they're the clusters that they came under into different action areas. So immediately what you're seeing, and we labelled that, we had an expert group that came together to label it, and then we took it out to the group who provided the statements and said, does this make sense to you? Fancy software, but what it does is gets people on the same page about broad areas of action, and they made sense to me. So I don't know if people can read that. There's things about partnerships, taking a systems perspective, having evidence and feedback, good governance, good regulations and policy. Food and nutrition came out as its own cluster.
Is this available, the research itself?
The outcomes or this?
Yeah.
We're actually publishing it at the moment, but I'm happy to share it because I'm not precious like that. So I'm probably meant to be. But yeah, I'll show you some of the statements so you can have a look at the whole lot of statements. So it's a really nifty software. And I will say that after doing this exercise, I've had a number of people come to me to say that they'd like to be able to do it themselves. I can't comment how difficult it is to actually do the analysis, but I really like the outcome. It's the visualisation that then the group can connect with. So in itself, that's great. We did that. The other thing that then it does do is these pattern match. So when people rated the statements in terms of feasibility and importance, the software was able then to produce these pattern matches. And on the left, you're seeing how important statements were, and on the right is how feasible. If things are parallel, if the lines are parallel, I know it's a slightly tricky graph to read, but if the lines are parallel, then the audience is really seeing equally important and equally feasible, which is kind of nice, I think. The theory, I had lots of things that I observed, but probably the three main things I observed is lots of things are seen as important, hardly anything seen as feasible. I'm reckoning that's the age of the audience and how tired we are, but interesting, scary, maybe. The other thing I noticed that creating demand for prevention was second highest in importance, but by far the highest in feasibility. So we think it's important that we create demand for prevention, and apparently we think it's feasible. That's good. I actually think that is good because there is a lot of evidence out there. I think we just need to get better in synthesising it and putting it under the noses of the right people. And the final observation that I was surprised by was around food and nutrition. It was near bottom on both importance and feasibility, which is quite scary when we know that less than 7% of Australian population meets the guidelines for fruit and vegetable intake. But people were feeling most negative about food and nutrition. I think that's worth pausing on, not today, but for people out there working in food and nutrition, we all know how important it is, yet we're professionals in the room that completed this survey just really were at a bit of a loss, I think. The other nifty thing, I think, you can see I get excited by the graphics, is this thing called a go zone plot. So you've done this in other parts of your life, I'm sure, where you have the importance down the bottom and feasibility up the side, and basically breaking it into quadrants. And what this does, I think, the green quadrant is all the statements that were rated as most important and most feasible. So in my view, that's where I'd be starting if I was going to invest. I might also be looking at the statements that were seen as really, really important but not feasible. And maybe there is a relatively simple solution for enhancing that feasibility. So I won't go through all these in detail, but these are the key actions that were in that green go zone plot. And so they're around the profile of prevention, funding for research, improving communication. So I'll pause there on communication because as a centre, we are really prioritising that. There's just volumes of data out there on the need for chronic diseases to be attended to, the value, cost effectiveness of prevention, but it is just so hard to get good key messages out there in a way that people can connect with. So we're doing syntheses of evidence to try and make, and graphics, visualisations of evidence to try and help that communication. But we're also supporting some research around the science of communication and science of public health communication and whether we can improve our abilities. Focus on primary prevention, learning from globally, and long-term funding and strategy for prevention. So just to give you a snippet of those ideas, happy to circulate the full details. So that was that concept mapping tool that is available. You can, there's a license to use the software. I'm told it's relatively easy to use. I'm not going to confess to knowing that, but when you get told by the developer, I think I'd take that with a grain of salt anyhow. So just to sum, structured process for seeing the problem from different perspectives, surfacing the complexity, articulating the system interconnections in those clusters, and then really getting down to the tangible actions of what people see as feasible and important. So project 2 is dynamic simulation modelling. So this is an area that I think as a centre we underestimated how attractive it is to people out there who are making decisions. So it really connects with my earlier statement around comprehensive approaches aren't necessarily the best way to go because there might be things that you can disinvest in or combinations of interventions. So really, this dynamic simulation modelling is a way of bringing together diverse evidence sources. We have research evidence, we have knowledge expertise coming together to build these computer models. There's a number of different methods, agent-based, which is around individuals, system dynamic, which is around looking at populations, and then discrete event simulation. What we're doing as a centre really is, if we think it's appropriate, doing some kind of hybrid modelling where we bring together the different techniques around a different problem. What it ends up becoming is this what-if tool with a really nice user interface that people can connect with. They can plug in different scenarios of interventions, different timings of interventions, and the computer modelling works out what the likely impact is of that scenario of interventions over time. So this is a graphic really just to say there are computer models that are a simplification of the real world that you can then use as a what-if tool for testing scenarios before you actually invest. Simulation modelling in and of itself has been around for a long time, so it has been used in other sectors in engineering, defence, economics, but it's really relatively new to public health. And I think the other thing that is new is that there's new software available, AnyLogic software, that creates an interface that normal people like me can connect with and understand and can engage with. The process starts with a group model building exercise, which is, for those of you who were fortunate enough to be here yesterday, is what we did. Slight different approach in that we undertake the group model session thinking about the architecture of the simulation modelling in mind. But it really is fascinating. I'm a psychologist by training, so you'll see I get excited by human behaviour. It's just fascinating watching senior professors and hospital CEOs coming together with sticky notes, and they love it, and they argue and they get on the same page. But that's what it's all about. It's about people coming together, bringing their different perspectives of the world, arguing if they don't agree, and then coming up with this complicated mess of what they think the drivers are of a particular issue. So that's a real event that happened around the unsafe use of alcohol in New South Wales. And what we ended up with, after all this interaction, at the end of 3 workshops, so the group come together for 3 one-days, which in and of itself is a huge commitment for a number of people, but they still came because I think they could see something tangible happening. And at the end, behind the scenes is all the stuff the really clever data boffins do. And this is what we see as a user. And when you get to this interface, these arrows are just showing the numbers of different things you can do, which I can't quite see from this angle, but you can put in different interventions. You can put different reach and different intensity of the interventions. You can limit it to a particular population if that's useful to you. You can stagger the timing of the effect or the timing of the intervention and then also the timing of the effect. And then you can put in different actions, the number of actions, run them one on their own, combined. You then name that scenario and then you run it and you get your output. And before people ask, the two questions I always get asked is, but what if you don't have data on the different effectiveness? That's fine. Where you have data, you put it in. Where you don't, the room decides what they think the best guess estimate is. So that's the best we've got, and we're talking to real clinicians and practitioners about what do you think the effectiveness of this intervention is. So we put that in. The other thing I'm asked is how accurate is it? Well, I'm not going to profess to say that I can see into the future, but what we do is we get the model to run backwards, and so we can test how accurate it has been in the past and see then if that increases our confidence in its accuracy going forward. The other thing I would say though is this is just one tool. I don't think it should replace your decision-making process, but it gives you another piece of evidence to bring to the table when you're deciding what to do. So just some results, just to give you a flavour. The three sort of things that came out, this is around the New South Wales population, looking at acute and chronic harms of unsafe alcohol use. The first finding that we were really impressed by was that the effects of multiple interventions aren't necessarily additive. So this is looking at ED presentations, and that's your baseline. When we added in what we thought the effectiveness of 3 a.m. Closing times of licensed venues, we saw a reduction in ED presentations. So I actually don't know your licensing rules in Victoria, I confess, but these are relatively new changes in New South Wales. We then looked at a 1 a.m. lockout in licensed premises. Again, significant reduction in ED presentations. But when you combine them both, you have no added value. So you can question whether you do need those two regulations or you just need one. Just sort of gives you that extra insight. The other one that is obvious to many good public health researchers, and I'm sure many health service clinical researchers, interventions can of course have unintended consequences, but this really visualises those in ways you weren't necessarily expecting. So this is ED presentations, business as usual. And then we looked at a scenario where we would raise the cost of alcohol in licensed premises. The ED presentations increased, not what we expected. We talked to stakeholders, people working in the environment, and their conclusion was, well, that probably means people are preloading before getting to the licensed premises and having incidents before they get there. Not what we would have expected. Preloading is a terrible term, isn't it? I have someone turning 18 next week, so I'll retract that. The other, this is a messy slide, so it's really just kind of trust me. It's really about being able to see that if you intervene in something now, you're not going to necessarily see it tomorrow in the current political cycle, or you might not for 10 years. So this is looking at brief interventions, so like telephone counselling kind of services, and really what we showed over with the graphing when it comes up is that really it took 9 years for anything to be explicit in the modelling in terms of hospitalisations. So that's is that comfortable for a person investing in brief interventions? Not sure. Oh, really? There you go. Okay, I'm going to talk quicker then. Okay, so summary, dynamic simulation modelling. Okay, the last one, which I can do quicker, is a third initiative, which got raised yesterday briefly at our workshop. This is an initiative called Prevention Tracker, where we're working with communities. So our first sort of, the case study was looking quite nationally, strategies at a national level. Then we were looking at state decision support, and this is working directly with communities. Our approach to working with communities, some similarities, some differences to how Steve and his team are approaching it. What we're doing is saying, there's a problem of chronic disease in your community. What does your community look like? So let's understand that system. Let's not just assume it's one thing or another. So we have a number of data collections where we're just looking at how can we better describe the workforce, the programs, the policies, all the different agencies. The organisational network survey great tool if people want to talk about it further, maps the connections between organisations and how they are and are not working together, hopefully to provide insights to how we could be more efficient with those agencies. The plan is, once you get a better understanding of that system, we will then work with that community to undertake some group model building work to better unpack what the problem is. And we're talking big P problem, for example, overweight and obesity, and then we're trying to get the community to think about a little p problem. So what can they intervene in today that will have some tangible small win in a relatively short time frame to try and keep momentum going? Establishing local action learning teams to really engage closely with this, and then reflecting on and hopefully scaling up. I did that quite quickly, but basically to say that we see our role as really hopefully bringing some expertise, some tools, some frameworks, some approaches that then that community will connect with and own and lead into the future. So, my summary, you'll be pleased to know. And I've said some of this earlier, complex chronic disease is the greatest health challenge. Prevention is effective. Systems thinking does offer promise, addressing those underlying causes. And I've written down the bottom there, and I meant to sort of add a few question marks. There are implications for practice, and I think we're learning about that. But I think if you're taking a systems perspective, you need to think about leadership differently. You need to think about distributed leadership. You need networks, and they're evolving networks. You can't force them. And again, I've noted their leverage points, but there's these things we're learning about what does that mean in practice. So I'll just end there and just with one. I like to end with something kind of positive. We get accused a lot in public health of being, those nanny state people. And I agree. There are some things that can limit your freedoms and your choices. And I thought it was a nice analogy yesterday at the end of Steve's workshop to talk about the paradigm shift in how we think about smoking. And I just suppose I'd like to reflect on things like seatbelt use, random breath testing, plain cigarette packaging. Everyone jumped up and down and thought that that was going to be the end of their civil liberties, but now we just take it as for granted. So on our website, we've starting to compile a number of little case studies of those nanny state issues and how they actually are saving lives. Thank you.